Okay, so good evening, everyone. So we are back with the third part of syndromic ichthyosis, and in this segment, in this video, we'll discuss neuro-ichthyotic syndromes. Okay, so in neuro-ichthyotic syndromes, you have the features of basic ichthyosis along with CNS features or features of neurological origin. So what I've done is since we are following the classification or some kind of grouping mechanism that we see in Rooks. That's what I've done in the third part, in making these three videos. The third part being the neuro-ichthyotic syndromes. And without much further discussion, we'll start with individual syndromes in the third part of the series. Let's move forward. Now, in neuro-ichthyotic syndromes, you have neural symptoms and ichthyotic symptoms. And it's a group of multiple distinct disorders. That means there are multiple different kind of syndromes which have been clubbed together. The common thread that ties all these syndromes together is that there are brain features or involvement of the brain CNS, and you have ichthyosis. The CNS symptoms does not improve with age. The only exception is in the syndromes is Refsum syndrome. In Refsum syndrome, we know that if you in later stages, if you continue the restriction of phytanic acid, the CNS symptoms might improve. But in nearly all of the neuroichthyotic syndromes, the CNS symptoms don't improve with time or with any other treatment for that matter. So let's start our discussion on neuroichthyotic syndromes. The first syndrome that we'll discuss is KID syndrome or keratitis ichthyosis deafness syndrome. It is caused by a mutation in the GJB2 gene, which encodes for connexin 26. Now, what are connexins? We have discussed that previously also when we were discussing 2 weeks prior the second part of ichthyosiform disorder, the second video that we made about 2-3 weeks back. Now, connexins are responsible for the construction of gap junctions. Okay, and they are very important for the transmission of signals between the cells. So, if you have any mutation in connexin 26, these signals are not transmitted through the cells, and because of that, these cells is not able to maintain a good homeostasis. That means that the cell is not able to maintain its not proper functioning. And since connexins provide a channel for the signals, how are these signals transmitted? Because of transmission of various materials, proteins, chemicals, okay? And one important chemical is calcium. So because of mutations in connexin 26, you have problems in calcium homeostasis and cellular, uh, transduction of signals. Okay? So KIT syndrome is autosomal dominant. But if there is hearing loss present, I mean, in Kid syndrome you have deafness. But if it is transmitted by a recessive mode, the hearing loss is much severe. Okay, so if the transmission is in recessive genes leading to mutation in connexin 26, then the hearing loss is much severe. Now let's look at the features of Kid syndrome. There is linear and spiny hyperkeratosis around the flexures, elbows, and knees. So remember this part, linear and spiny hyperkeratosis. Okay. Hystrix like scaling on limbs. Remember what is hystrix? If you remember our previous lecture, hystrix comes from the word for porcupine. So what we're trying to say is spiny or very pointed. Spiny or pointed. Like scaling on the limbs, scattered follicular hyperkeratosis, which can involve trunk, but in later part of life, trunk often gets spared. So it mostly starts on the limbs. Symmetrical, well-demarcated hyperkeratotic warty plaques on scalp, ear, face, trunk, and limbs. There is thick perioral rugae. So this is a very characteristic feature of Kidd syndrome. And because of thick perioral rugae, so what do we mean by that? Let's say if this is the oral opening or mouth, okay? You have thick furrows around it. Okay, thick furrows. These are thick perioral rugae, and they may give an appearance of leonine faces. So, what are leonine faces? In which the face looks like a lion. Okay, a lion-like face, leonine faces. There is extensive scarring alopecia of the scalp, loss of eyebrows, eyelashes, and body hair. So there is loss of hair. Kidd syndrome is associated with invasive squamous cell carcinoma and hair follicle tumors like trichoepitheliomas or trichofolliculomas. Okay, and there is a significant chunk of tumors that undergo malignant transformation in hair follicle tumors. So remember that Kidd syndrome, apart from keratitis, ichthyosis, and deafness, has a good association with malignancies, mainly SCCs and hair follicle tumors. Okay, let's move forward. There is reticulate palmoplantar keratosis that resembles a grained leather appearance, which is characteristic. Okay, so in grained leather, the PPK, the palmoplantar keratosis, it gives a leathery feel to the skin. There's progressive nail dystrophy and shedding, acneiform eruption, cyst, abscess, discharging sinuses, which we usually see in follicular occlusion triad, can be seen in later stages of Kidd syndrome. Chronic infections can occur with premature caries, oral leukoplakia, short stature, breast hypoplasia, cryptorchidism. These are all the other features of Kidd syndrome. Progressive corneal vascularization. Remember, this causes the keratitis part. Okay, keratitis part. Now, progressive corneal vascularization can lead to photophobia or blindness in about 75% of patients. So we have discussed keratitis, we have discussed ichthyosis, and deafness can be seen severely in recessive transmission of diseases. So these pictures are taken from Rooks and Bolognia. So can you see this radial furrows? Let me just change the color. You can see this radial fissures thickening, perioral thickening, which gives the appearance of a leonine facies. Okay, I'll just erase the marking so that you can observe, or else you can go to Rooks 63.34 and look at these pictures. Okay, there is PPK, palmoplantar keratosis, with a grained leather appearance. Let me change the color. Okay, so leathery appearance is there on the palms, and in fact, this kind of periorificial furrows and periorificial red plaques can be seen. This is around the eyes. In fact, you can see a bit around the nasolabial folds. This is just the PPK, and this is invasive squamous cell carcinoma observed in the background of Kidd syndrome. Okay. Now, understand that if we want to summarize Kidd syndrome, it is because of GGB2 mutation in connexin 2016. The keratitis part is because of progressive corneal vascularization leading to photophobia or blindness in 75% of patients. The ichthyotic part usually starts in as case of warty or very spiny hyperkeratosis over the limbs, followed by trunks. Okay, and it includes perioral furrows, orificial red plaques, leathery field palmoplantar keratoderma, and has a good association with squamous cell carcinoma and hair follicle tumors that are the malignancies. The deafness part is more severe if the diseases are recessively transmitted, and otherwise Kidd syndrome has an autosomal dominant transmission. Clear? Let's move forward. Now, how to manage a case of Kidd syndrome? You should have early and frequent audiological and ophthalmological assessment. This is to look at the cornea, to look at keratitis, and just to look at hearing loss. Hearing loss. Hearing aids, cochlear implants, speech therapy, all can be utilized to tackle a case of hearing loss because of Kidd syndrome. Okay. Eyes will require lubricants, antibiotics, steroids, cyclosporin drops, and if corneal transplants are to be considered, they usually tend to fail. Okay, the graph uptake is not that good for the corneal transplant to be successful. In skin, systemic retinoids like acitretin and alloretinoid have shown to have some moderate benefit. or a simple modest benefit. So this can be tried when for the skin involvement. So we have taken care of the deafness part, the keratitis part, and the ichthyosis part. Clear? So all emollients which are paraffin based, regular cleaning, taking care of recurrent skin infections, and systemic retinoids are the mainstay of treatment. Now, from henceforward, we just have few symptoms left now, and we'll quickly go through them. The second is CEDNIK syndrome. CEDNIK is cerebral dysgenesis, neuropathy, ichthyosis, palmoplantar keratoderma, and this group together is used by mnemonic CEDNIK. So cerebral dysgenesis, neuropathy, ichthyosis, and keratoderma. So this is CEDNIK syndrome. It is caused by SNAP29 mutation, which causes a mutation in the snare protein. Now, snare protein, if you have read a bit about Botox, you will understand what the snare protein is. So, it is just a protein required for proper vesiculations or proper outpouching. For example, if you have a membrane and there are material inside the membrane that we need outside, so we have a material here, so snare proteins help in formation of vesicles. So it forms this kind of vesicles, and then there is outpouching. After that there is outpouching. Clear? So this is required. This outpouching mechanism requires a proper functioning snare protein. Clear? Now, if you remember about discussion on lamellar bodies while discussing basics of keratinization, lamellar bodies are required for proper cornified envelope formation. Clear? Now, where do we get lamellar bodies from? We get it from the Golgi apparatus. Okay, so lamellar bodies arise when they are outpouching from the Golgi apparatus. So here, this is the part of the Golgi apparatus, while this eventually will form lamellar body. Clear? So lamellar bodies outpouching from Golgi apparatus require snare protein, and when it is mutated, there is abnormal maturation of lamellar bodies and proteins. So the first disorder, Kitts syndrome, the mutation was in connexin. In second disorder, CEDNIK syndrome, you have mutation in the lamellar bodies outpouching. Clinically, it presents as ichthyosis with or without palmoplantar keratoderma. The neurosymptoms of cerebral dysgenesis is hypotonia and developmental delay. Rarely, hypomyelination, seizures, and early puberty are also seen. Let's move forward. So this picture I've taken from this article, which I have mentioned here, and you can see this hypertaylorism or widely spaced eyes, low set ears, this kind of cerebral features that we usually see in Down syndrome or other neurosyndromes, coupled with ichthyosic scalings over the limbs. So here you can see scalings. You can see a little bit of nail dystrophy, but that is not the major factor. The major factor is the skin scaling. Let me just draw it again. So from here onwards, or from here, remember that there is palmoplantar keratoderma also, okay? And that is why the soles would be much severely affected too. Let's move forward. The third syndrome is Stormorken syndrome. It is an autosomal dominant channelopathy affecting calcium hemostasis. So it sounds a bit like Kidd syndrome because there also their problem lies in the calcium homeostasis. The problem lies in the channel formation. It is again Kidd syndrome is another example of channelopathy. So Stormorken syndrome, there's gain of function mutations in the STIM1 gene or ORA1 gene. These are same gene, and they're required for extracellular calciums. So because of mutation, you have excessive extracellular calcium. The calcium is more on the outside of the cells. So just remember that in Stormorken syndrome, S for Stormorken, S for STIM1 gene mutation, you have problems in the calcium levels. So the features, and I've used every letter of the word Stormorken. The features of Stormorken syndrome are S for small eyes. So you have meiosis. So meiosis is just a name for constricted pupil. Okay, constricted pupil. T for thrombocytopenia, platelets are less. O for old, which means there's profound or significant muscle weakness. R for reading issues. So because the patient has dyslexia, M for migraine, O for osteopenia, R for reduced sweating, K for keratosis, which leads to ichthyosis, E for exsanguination because there's intense bleeding. Remember thrombocytopenia is happening. And N is Nata. Nata is Hindi slang for short stature or Hindi word for short stature. So every word of the Stormorken syndrome, I've utilized it to give you all the clinical features, so you can easily remember it. Let's move forward. The fourth disease is Refsum disease, and I think we have all read about Refsum disease in our MBBS days, but mostly we read about the neural issues. We'll just have go through the skin involvement here also. Now, Refsum disease is all known as Heredopathia Ataxia Polyneurotiformis. So you need not remember it. Just you should have an inclination that this name is nothing but Refsum disease. It's an autosomal recessive disorder, ultra-rare neurocutaneous lipid storage disorder. Now, lipid storage disorders can also lead to ichthyosis because of problems in the lamellar bodies. Because that's what lamellar bodies contain, isn't it? They contain lipids. Deteriorating vision and hearing, ataxia, neuropathy, and mild ichthyosis. So, majorly the problem lies in the brain with ichthyosis. The mutation is in the gene PHYH, which leads to normal PHYH gene leads to oxidation of phytanic acid, but when that gene is mutated, phytanic acid is not properly oxidized. When it is not oxidized, it leads to accumulation of phytanic acid. So phytanic acid increases, and phytanic acid is derived from plant chlorophyll. So normal levels of phytanic acid are barely detectable, but in Refsum disease, they constitute to about 5 to 30% of the serum lipids. Now, increased phytanic acid, what it does it replaces other fatty acid in lipid-rich tissues and interferes with membrane structure and function. Now, a large part of brain is also made by lipids. And we require proper lipid concentration for skin function because of lamellar bodies and the brick and mortar model and the cholesterol esters in between. So we need that kind of lipids. Clear? So what phytanic acid does is it replaces other fatty acids in lipid-rich tissues, and because of that, it leads to disorders or the features. The onset is in late childhood. There is progressive retinitis pigmentosa leading to night blindness, and if not controlled, later failing vision and constricted visual fields can be seen. The CNS issues arise majorly in the adolescents with anosmia, that is not able to smell properly, dysgeusia, that means not able to taste properly, sensory neural hearing loss with tinnitus in 50% of patients, and cerebral ataxia. Mild sensory-motor polyneuropathy of type 4 plus hypertrophied peripheral nerves plus elevated CSF protein are characteristic of Refsum. So we can just remember it as a clinical triad or a laboratory triad, but that is not that important from dermatology point of view. 30% shows hand and feet deformity like shortened metacarpal and metatarsals, and 25% have ichthyosis, and the ichthyosis looks a bit like ichthyosis vulgaris. That means thicker scales on limbs. Okay. So remember, Refsum disease is an example of lipid storage disorder. Why? Because increased phytanic acid, because of the mutation PHYH gene, is replacing other fatty acids, and the function is not able to be properly performed. The management includes early diagnosis, exclusion of chlorophyll, which is mandatory. The patient cannot have chlorophyll, so no green vegetables because they're rich in phytanic acid, no animal fats because they are phytol. So phytanic acid can be made from phytol also. Daily intake should be restricted to less than 5 milligram per day. Now, rapid weight loss can mobilize tissue phytanic acid, and this can lead to acute clinical manifestation. What do you mean by that? Now, I have told you that normally phytanic acid makes about barely detectable levels. In Refsum disease, it is about 5 to 30% of all lipids. Now, all animal tissues do have a certain amount of phytanic acid, but that's barely detectable. But if there's rapid weight loss, the fat cells will start to get disintegrated because of weight loss, and they will release phytanic acid in the system. And that leads to acute clinical manifestations. Extracorporeal elimination of lipoprotein phytanic acid complexes, which can be done by lipid apheresis, is another treatment. And it is same as plasmapheresis. You just take the blood out, remove the phytanic acid-rich cells, and then pump the blood back in. Later, phytanic acid pour diet continues throughout life. So no phytanic acid. Daily intake has to be less than 5 milligram a day. Let's move forward. The fifth disorder is multiple sulfatase deficiency. It's a rare autosomal recessive disorder. It's a lysosomal storage disorder, also known as mucosulfuridosis. Just remember multiple sulfatase deficiency. So all known sulfatases is an enzyme, they got deficient. And because of this deficiency, there is accumulation of glycosaminoglycans and sulfated lipids. The mutation lies in SUMF1 mutation, and because of that, the post-translational modification of sulfatases do not happen. So what do we mean by that? In multiple sulfatase deficiency, you have uh, a lot of many enzymes in the cells which are responsible for sulfation of proteins. That means they are responsible for addition of sulfur molecules to proteins, and this addition is done by sulfatases. SUMF1 gene is responsible for modification of sulfatases so that they can act properly. If there's mutation in SUMF1, then the enzymes are not sulfated, they are not properly modified, and they cannot do sulfation or addition of sulfur molecule. So because of that, there are multiple proteins which gets affected because they lack that kind of sulfation. There are four different types: very severe, severe late infantile, mild late infantile, and juvenile multiple sulfatase deficiency. These are just the types mentioned, Rooks. So just for theoretical purposes, you may know that. The phenotype or the level or the intensity of clinical features are directly proportional to the enzyme activity reduction. There's mild ichthyosis with developmental delay, failure to thrive, and Hurler syndrome. Now, the first neurological sign to be seen in multiple sulfatase deficiency is that the child can no longer sit unsupported and they start to lose their communication skills. This is the first neurological sign. Motor delay seen about 80%, language delay 60%, hearing loss 65%. Treatment in the future may require enzyme replacement therapy. Now, the enzymes that require modification by SUMF1, and these enzymes include a lot of sulfatases. If we replace the altered enzyme with a proper functioning enzyme, everything should be all right. So that is what enzyme replacement therapy is. The sixth disorder is Sjogren-Larsson Syndrome. It's a rare autosomal recessive disorder. It has, if we mention this as a triad, it has congenital ichthyotic hyperkeratosis, okay, spastic diplegia, and mild to moderate intellectual disability. So if you want to remember, S means spastic diplegia and L for learning disability or intellectual disability. Just remember it using this learning trick. The mutation lies in ALDH3A2 gene, which is responsible for microsomal fatty acid dehydrogenase enzyme. If that enzyme is deficient, the oxidation of fatty acid does not happen and it leads to accumulation of fatty acid. It sounds a bit similar to Refsum disease, isn't it? Here, there the phytanic acid was getting accumulated. Here, the fatty acids are getting accumulated. Additionally, there's increased LTB4. It's a chemical from the leukotriene pathway, which leads to pruritus, leads to itching. And the problems in hypoxylin pathway leads to ichthyosis. How does that happen? It's beyond the scope of this video lecture, but just remember that ichthyotic features are because of problems in the hypoxylin pathway. Abnormal lipid composition of myelin leads to the neural features of the disease in Sjogren-Larsson. So, in Sjogren-Larsson syndrome, the birth may be preterm. Why preterm? Because leukotrienes are required for proper contraction, proper labor contractions and all. If that is deficient or increased or not available properly, improper inactivation can lead to preterm birth. The skin is dry and mildly red. Scaling occurs in about 3 months of life with mild erythroderma that can persist. There's keratotic lichenification of a flexure neck and mid-abdomen. The face is spared. There is severe and persistent pruritus, so that is important. In Sjogren-Larsson, you have severe pruritus. Neural symptoms occur in less than 2 years of life, delayed milestones, spastic diplegia, spastic tetraplegia, seizures in 40%, speech is delayed, dysarthria, leukoencephalopathy. Eyes will show glistening white dots surrounding the fovea, which are the crystalline exclusion. And these are very characteristic features on fundus examination. So if you ever suspect a case of SLS or Sjogren-Larsson syndrome, have an ophthalmic evaluation. It's a must to look at the retina. Interleukin-13 blockers or oral xylitol has been shown to improve pruritus in patients of SLS. Retinal therapies with etretinate and acitretin improves a bit on the ichthyotic syndromes. So for dermatology, two features are very important: pruritus and ichthyosis. For pruritus, oral xylitol or IL-23 blockers can be used. Sorry, IL-13 blockers can be used. While to manage ichthyosis, retinal therapy with etretinate and acitretin can be used, along with emollients and other regular cleaning and all. So this picture I've taken from Rooks and Bolognia, and here you can see this kind of diffuse scaling and keratotic lichenification. Can you see this kind of lichenification over the trunk, periumbilical, extending from the axillary folds also? So this is the lichenification keratoderma. This is spastic diplegia of the lower limbs, and these are the glistening white dots around the fovea. And this is very characteristic of Sjogren-Larsson syndrome. Let's move forward. The seventh disorder is Desmon Syndrome. It is also known as Ichthyosis deafness photophobia syndrome. So it is ichthyosis plus hearing loss plus photophobia. Okay. Or ichthyosiform erythroderma, corneal involvement and deafness, or Mednick-like syndrome, or AP1B1 deficiency. We just have to remember Desmon syndrome, and we have to remember ichthyosis plus deafness plus photophobia. Just remember these three words. It's because of recessive loss of function mutation in AP1B1 mutation, and it is just required for vesicular function. Now, remember in CEDNIK mutation, in CEDNIK syndrome, you have problems in the snare protein. Okay, and snare protein was responsible for proper vesicle formation. When the snare is mutated, the vesicles are not properly formed, leading to ichthyosic-like features. A similar thing is happening in Desmond syndrome also. That is why it is named as Mednick-like syndrome, because Sednick and Mednick are similar group of disorders. So Mednick-like syndrome, Desmond syndrome. At birth, there is features are of an autosomal recessive congenital ichthyosis with ectropion. There's severe failure to thrive and developmental delay. There's profound sensorineural hearing loss with sensorineural hearing loss with vascularizing keratitis. Enteropathy and hepatopathy are also features of Desmond's syndrome. So again, we are back with this table, which has summarized summarized the disorders, the gene which is mutated, and what is the problem in what is the protein that is synthesized by that gene. So let's uncover the last part of this table, the neuro-ichthyotic part. So the KID syndrome is because of mutation in GGB2 leading to connexin 26 mutation. SEDNIK is because of SNAP29 mutation leading to snare protein problems. Stormorken syndrome is because of STIM1 leading to calcium modulator protein problem. Refsum disease is PHYH leading to phytanic acid oxidation deficiencies. Multiple sulfatase deficiencies because of SUMF1. Sjogren-Larsson is because of ALDH3A2, and Desmond is because of AP1B1. So I've received multiple comments from the last few videos that we need some genes regarding genetic syndromes. So I've tried to combine all of the genetic syndromes together in this table. So what we can do is I'll just remove these markings so that you can take a screenshot of this. And if you just want to have a look about the various genes which are mutated in all the neuro-ichthyotic syndromes. I'll just wait 2-3 seconds till you take a screenshot. Okay, so let's move forward. So these are the chapters that I've used to make this video, but if you've gone through this video, you don't require to read that, except maybe the rarer syndromes. So with that, again, I would like to request that if you think that the content is good, please consider becoming a member. It is at a discounted rate till 31st of December this year, and a lot of different things are going to be there. I have a separate video on membership and what the membership offers, what exactly is membership. I'll put a link to that video here, and I'll also put the link to join the membership. Okay, so without much further ado, we have completed through 3 videos the syndromic ichthyosis. I've tried to club them into various headings so that it's easier to remember about what all different problems may arise leading to ichthyosis, and why with ichthyosis you have other features also. So in this video we've discussed about neuro-ichthyotic syndromes. In the previous video we discussed about disorders of cornification, and in the first video we discussed about problems in cholesterol biosynthesis and how these will lead into ichthyosis. Okay, and this I understand and I agree that this is the most boring part of a chapter which is itself not that interesting. So thank you for watching the previous part 1 and part 2 of ichthyosiform disorders, which were very well appreciated by the viewers. And the third part, which was covering the syndromic ichthyosis, I've split into 3 parts: 3A, 3B, and 3C, so that we can easily understand about syndromic ichthyosis. So without much further ado, I would like to say bye bye. So adios and bye bye.